Dr. Sarah Collins, an orthopaedic surgeon based in Queensland in Cairns. And this talk this evening is one of our monthly information sessions. It gives me great pleasure to introduce Dr. Jeannot. He is a orthopaedic surgeon who travels regularly to Cairns to provide us with a medico-legal service, and he's going to talk to us about causation, and then we're going to ask him some questions.
Okay, thank you, Sarah.
Thank you.
Right, good evening, everyone, those who are with us in the room and those who are at home. Just a little bit of background about myself. I'm a UK orthopaedic surgeon, but I was born in Australia, so it gives me a pass to be here, I hope. So I've currently been working primarily out of Brisbane for the last 20 years. So I actually retired from operative practice about 12 months ago, and I spend most of my time doing medical legal examinations for various organisations. So this is a pet topic of mine, which is the causation analysis of work injury. So I hope you will learn something this evening. So the big question is causation analysis. Why do we bother to do it? What is medical versus legal causation? How you should do causation analysis, and why use evidence-based methodology? So those are the objectives of tonight. So why bother? Well, determination of causation is the key in a medical legal setting to determine financial responsibility. It's all about cost shifting, basically. Who's going to pick up the tab for whatever happened in a work cover case or road accident? It's the injuries sustained. However, not only can you sustain an injury in a work cover or road accident situation, you can also aggravate a pre-existing condition or a condition that was asymptomatic and cause problems that way. Unfortunately, the list of diseases and conditions inappropriately attributed to the workplace environment is actually quite long. All right. So we need to have an appropriate definition. So causation is an event, condition, or characteristic that plays an essential role in producing an occurrence of the disease, injury, or condition. So that's important when we have that definition. So what are we talking? Medical causation of what? Is it a new injury? So clearly if in a road accident and you break your leg, there's obviously a causal relationship. However, you could have an aggravation, and these all actually have legal definitions. So an aggravation is a permanent worsening of a condition. An exacerbation is a temporary aggravation, if you like. So the condition goes back to what it was before. You can have an acceleration of the condition, and I often will use the terms aggravation and acceleration synonymously depending on the condition. So not only can it be aggravated in symptomatic terms and or pathological terms, and the conditions present, if you like, may be brought forward by whatever the event is, which is the acceleration, or there could be just simply a recurrence of a pre-existing problem. So it's important to have all these concepts. So the question is, we're all intelligent people, doctors, can we accurately assess causation? Well, the bottom line is probably not, because we do not get taught it in medical school. You do not get taught in your medical training, either as an orthopedic surgeon, occupational physician, and so on and so forth. But it's really the link, if you like, the nexus is because we're intelligent people, we must be able to control causation. Surely we're that intelligent. Well, the answer is not really. And there's a lot of examples of the misattribution of work causality. So, for example, the first episode of angina occurs when Joe walks up the stairs at work, and the doctor should really recognize that this is when the angina happened, but not why he had angina. Just because he's at work, that's not responsible. Work's not responsible. Okay. Similarly, with musculoskeletal conditions, okay, is work just the setting in which the symptom occurred? Okay. So most of the time, when a first episode of back pain, shoulder pain, knee pain occurs with normal activity, and that's critical, physiological activity, not a pathological activity or incident. A lot of work doctors or general practitioners and orthopedic surgeons just say, well, work must be the cause of that problem. And so the misattribution of work causality is therefore very, very common. Okay. All right, so why do we bother with scientific causation analysis? Fraud is common. Actually, it's more common than you think. So if you look at the literature from the United States, there is fraud in about 40% of independent medical assessments, medically legally. Okay.
Right side.
Now, there's actually different types of fraud. Now, the out and out malingerer, thank you, Jim, is actually quite rare. I've probably done, and I'm not kidding, probably done about 20,000 medical reports in my time, and it's actually very rare. However, you get the claimant who has an accident, they have symptoms go away, but funnily enough, when they come to their independent assessment, they have a resurgence. And then you get the claimant who's had an injury, the symptoms get better, and they come to their examination, and the symptoms, funnily enough, slightly worse again, will be alleged incapacity. Now, this is based on American studies. My personal opinion is I don't think it's as high as that, but overstatement and embellishment is kind of a natural thing to do because with the money involved, I might just bump it up a little bit for whatever reason. We as doctors are not very good. I think I'm probably better at it than most because I make it in business to do so, but I carefully look at all the pre-injury records. I look at the clinical course, records, physiotherapy records, which are relevant. Someone's had physiotherapy, for example, and the pain is actually gone or resolved 6 months after the injury. That's funny enough, it's back again. That's an inconsistency, which is not good in a medical legal mediation, I must say, especially if I pointed it out, use it as a bartering tool. All right. Anyway, so that's why we bother to do it. So why are doctors no good in detecting fabricated or exaggerated claims? Well, we don't have any training for starters. We have lack of insight, and this applies more really for treating doctors. They're not really looking for any fraud activity, if you like. The confidence of a doctor is often overstated. We often think we're much better than we are picking things. And this is a statement again from Professor Ranovaya, who's very big on all this in the United States. He said medical legal professionals who claim they cannot be fooled actually may have been fooled already and they just don't know. Okay, so that's important, but bear that in mind. So treating healthcare providers is always worried to overlook something or misdiagnose. And if in doubt, they kind of assume what the claimant, which in their case is a patient, is telling them is correct. So they assume that. And they're not really want to have a big fight with the patient if they can avoid it. So they kind of sort of smooth the waters, if you like. And sometimes there can be a lot of self-interest on behalf of the doctor because they've got to work out the claim going. I'll see you next week. We'll see you next week. We'll see you next week. And then continue. There's lots of willing that goes involved in that and so on and so forth. And the same with requests for surgery, which I've seen personally. I'm actually involved, I can't say the state, but I'm actually involved in a forensic unit in a different state, looking at what doctors have been doing, and some of the doctors you'd be quite amazed at the rorsch that goes on financially. And you've been talking of hundreds of thousands of dollars of money that you pay in insurance for. All right. So in medical legal claims, certainly the treating doctor doesn't look, won't find, and will miss a lot. Okay, so that's important to know that. The same with a assessor who's not really on the ball about maybe early on in their career with doing this. So causation, what does the science say? Well, there's a large body of scientific literature on many conditions and injuries about non-work related factors. So for example, genetics. Epigenetics is really the influence of environment on that situation for people who, for example, smoke or drink heavily or whatever it happens to be. Age related comes into it as well, obviously. So there's a lot of age related degenerative changes which are relevant. And then there's the actual individual themselves, which is the anthropometric aspect of any claim in terms of an individual. So does epidemiology help? Well, it certainly addresses, in and of itself, it is insufficient to attribute causality, but it can provide some circumstantial evidence. So the example here is, because you've got grey hair, there's a much higher incidence of myocardial infarctions, but they're not really related because you're getting older. So there's a relationship, but it's not causal, if you like. So all that sort of thing comes into it. Now, this is important. Medical causation versus legal causation. So the lawyers in the room will understand it. So the medical causation, there has to be a cause in fact. So some incident needs to have occurred and something needs to have happened after it. So you bend over, pick up something, you get back pain. Okay, so that's cause in fact. But then you have to have maybe what's called an inductive argument. So that has to be an obvious link and things all sort of line up. If you look at population studies about the same thing happening to lots of people and the same thing happens, randomized trials, a lot of this stuff often will refer to medical conditions as well. So, for example, smoking very much causally related with lung cancer. We know that as fit studies and so on. But there's lots of different studies for different conditions with that sort of information. Now, in a legal sense, there has to be what's called a proximate cause as well. So there has to be, if you like, you have to have both together to really kind of prove a negligent case, if you like. So there has to be the legal causation as well. You know, as a defendant responsible for whatever happened. You know, there may be provided shoddy equipment that was not maintained or whatever it happens to be. So there kind of has to be both together. You have to have a cause in fact, then the proximate cause as well. And then there's all the legal aspects to it, you know, deductive logic, you know, there's the individual case and circumstances and so on. And this is where your expert opinion comes in. And as we know, it's an adversarial system. So there's basically, you know, the defendant, plaintiff, that sort of arguments. So legal causation, we talked about this, summarize it, two separate components, the cause in fact and the proximate cause, and you have to have both to have a successful claim. So a lot of people don't realise that. So cause in fact, just to reiterate really, if one event brings about another, the former can be considered the cause of the fact of the latter, regardless of the number of events in between. So it could be just one event, or could there be multiple events. So an example here is the squeeze of the trigger. A bullet fires to hit a target, but there's a whole lot of things that go before that. It's the pressure on the firing mechanism would indisputably be the cause, in fact, of the target being hit. So there's all these sequences, if you like that. This is something that is a common law principle, so it's so-called eggshell plaintiff or the thin skull principle of law. And you have to take the victim here, but it's the claimant, you have to take them as you find them. And the defendant is often liable for injuries in someone who's vulnerable anyway. So that's a common law concept that's out there for that. So that's something that's often argued about in a legal setting. All right, so medical causation requires what's called a risk causation analysis. So it's very important to analyze all the information you have when you see a claimant. So the risk is the probability that an event will occur. And in epidemiology, this is the probability that a particular outcome will follow a particular exposure. So, for example, if you're going to have a fall, it's quite likely that you'll have some injuries, but not always, and that type of thing. So what is a risk factor? There's lots of risk factors around it. So it can be environmental, behavioural, and biological. So a lot of this refers not only to maybe an injury, but to conditions as well, you know, things like lung cancer and things which are not really obviously work related and so on. So there's lots of studies that can prove risk and analysis. So an example in my situation would be someone presents with carpal tunnel syndrome. Is their work related in some way? So whether they have a very repetitious job where their hands are continuously flexed, and there is some evidence for that. So there is a causal relationship. But if you're just, for example, sitting typing, you know, like Ash and Nat would be, and moving a mouse, that's probably not going to cause carpal tunnel because they have a genetic predisposition to it, and it's very common in the female population, which actually get older. Okay. All right. Now, what about work relatedness? Well, it's very complex, or can be a complex issue. It can be very easy. It can be very complex, and it may or may not be obvious at the time, but it can be intuitively believed to be the cause. So a claimant naturally thinks, well, I was at work, I've got some shoulder pain, so something in my workplace must have paused it, so they look around to what they might have been doing at the time, and they say, "Oh, it must have been when I went to put a box above my head," or something like that. So that, you can see why intuitively someone might want to do this, but you have to analyse medically and legally in terms of causation. Is there a case to answer? And the two actually may be mutually exclusive. So why is this all important? Well, of course, we have workers' compensation schemes, we have common law schemes, and we have CTP, and so on. If you like, the rules, regulations, and definitions vary between the states quite a lot, actually. I work in Queensland, Northern Territory, and Victoria, and one of the difficulties, well, it's not a difficulty because I'm used to the system now, but in Queensland, you have to have a significant relationship to work. That's a legal word. It has to be significant relationship to work, and the work related to the condition. In Victoria, a different word is used. It's a material relationship to work. So material, especially just about the floor level. You can turn up to work with a musculoskeletal complaint, and you'll probably get it covered in some way. Whereas that's certainly in terms of joint replacement, they pretty much will cover joint replacements for arthritic conditions in a work setting. Whereas Queensland, very, very difficult to do that because of the legal, same injury, same setting, whatever you want to call it, but the statutory law is different. So I have to write reports differently because of a legal context in that situation in terms of legal causation. Legal causation can be different from medical causation. So that's what you need to be aware of. All right. So with medical causation analysis, you must have an accurate diagnosis. You have to confirm that an event took place. So this is what I'm doing in the pioneer lead situation. I have to be satisfied that the event could cause an aggravation of a pre-existing condition, or an acceleration or exacerbation, whatever it is. It has to be medically probable that the event caused the injury. And you need what's called a systematic approach to doing the causation analysis. And I suspect many of you haven't heard of the Bradford-Hill criteria. This is all in the what's called the AMA book for the injuries and causation analysis. A big book about, I don't know, a couple of inches thick, and it's worth reading. There's a whole section on medical causation in there. So something called the Bradford-Hill criteria, which you should use. In essence, what you're asking yourself, does A result in B? Is there an association, cause and fact, and is there a causal association maybe legally in terms of what's gone on as well? So these are the Bradford-Hill criteria, which you need to think about. It's actually very important. So there has to be a temporal relationship. There has to be what's called a strength relationship, and I'll go into these in a bit more detail. Dose response relationship. There has to be consistency, plausibility. So maybe some experience has been shown to cause that problem. For example, has to be specificity, coherence, and analysis. All of these are relevant to the assessment of causation. And you can look these up on the internet. So this is the temporal relationship. So this is very important. So the event or exposure, we call that A, must precede the outcome B to form a causal relationship. But just because A preceded B does not confirm A caused B. So this is as far as some of my colleagues go when they do a medical need assessment. It frustrates me because they're intelligent people, but they don't apply science or common sense to this. And this is the sort of legal term they use: post hoc ergo propter hoc. After this, therefore, because of this. So what that means is just because the black cat crossed the road and caused an accident, there's a causal relationship, but one did A didn't cause the other. Really. The analogy here is the rooster crows and the sun rises. So there's a perfect temporal relationship. But just because the rooster crows doesn't mean the sun rises. Yeah, so that's the sort of the analogy. The strength of association is how many times the event or issue is observed. Reporting it, so that might be, for example, maybe over a period of time, injury perhaps, for someone who's working in a manual occupation. So you can imagine someone who's exerting themselves manually, manual workers, particularly, for example, in this situation, painters who are painting ceilings with their hands above their head all the time are more likely to get sort of shoulder conditions. That there's a good strength relationship to that. Now, other thing here is consistency. So there has to be, if you like, a lot of similar observations by different observers in any particular association, and preferably confirmed on numerous studies. So, for example, you might go to that carpal tunnel analogy. There's lots of studies showing, the incidence or prevalence of carpal tunnel condition in certain sets of workers, for example, or whatever that happens to be. Specificity, well, this is the observation is specific to the physiological system or event. So, in a back situation, someone bends over and they may have pre-existing degenerative change and then they have a worsening of the condition. So there's some sort of specificity to that. The temporality is, A precedes B. There's more likely to be a causal relationship to it, if you like. So it's a little bit on the temporal side of it. The biological gradient is not so relevant for injuries, but it's relevant, for example, if you're a smoker and ingesting nicotine, you're more likely to get lung cancer, for example, or if you're exposed to chemicals on a regular basis, you might get asthma or that type of thing. And this is where you get the so-called dose response curve. So the more you smoke, the more likely you are to get cancer.
So can I just ask, so if you're looking at the current issues that are in fines and dust going forward, is there a smoker, does that factor into it, or is that because much better reduce smoke capacity and then you're actually exposed to this dust in the environment? Does that actually still become a cause for that injury that anything like in the workplace?
Yeah, well, I think Jay's referring more to occupational health exposures. The big thing at the moment is those guys telling us this stuff, stack stuff, which I can't believe that it's gone on for so long, really. It's been going on for a long time. But, so there's all that's a kind of a good dose response curve.
So I think the dose response curve, I think what you're saying is that it frequently is like a straight line. The bigger the dose, the worse the effect.
Yeah. Okay.
But then if you're exposed to this facility dust and the energy smoke, those response curves goes through the roof.
Yeah, that can be.
So that's what we're used to talking about, a dose response curve.
You has to be sort of like this. Yeah.
Well, yeah, it can be, this is a very simplistic one, increased exposure, increased risk. But then what you're adding in is the complexity. So there's an orthopedic equivalent of that. If you lift 100 boxes, you might get back pain. If we lift 100 boxes and 25 of them have 100 kilos in them and you don't know, then you might have a particular relationship between the dose, the lifting, and pain.
The interesting thing, certain individuals may be more prone to it because they may have pre-existing generation, for example, they don't know, or their body build is not appropriate for them to have that occupation.
But it's still part of the causation. It's mitigated slightly.
I mean, what I'm trying to really illustrate, there's many facets to the causation analysis, and some maybe only, for example, 4 of those things apply to any one condition. This is very generalized concept, really, of the 9 criteria that are used. Probably injury-wise, it's probably to count maybe 4 or 5 that are highly relevant to an injury situation. This is quite important. Is it biologically plausible? That something A happened and then cause B. Does that actually make sense? In fact, there's a gentleman I saw today who was under a truck changing an oil filter. He got a definite wrist injury, but then a surgeon in town who wants to do a shoulder operation. Wants to do an operation on the shoulder, but the incident happened 2 years ago. Oh, he's only recently got shoulder pain. So the temporal relation is way too much. There's no evidence in the medical records that there was a shoulder pain very long. 2 years ago. He's blind, but I told everyone I had shoulder pain right day dot.
Apart from his doctor.
Apart from the doctor and the therapist, in other words, and the written word carries more evidence. So I actually want to be nice with it, but I can't support it. Remember the word for work application is significant relationship to work. You may have got a way with it in Victoria, they may well have covered it.
Do you tell the patient?
Yeah, I'll tell you right at the beginning, I pushed a little bit. In some patients, or claims you can push a little bit, but then you get a bit of pushback, you sort of back off. It's just trying to get the right history. if you like.
Did we get worried about some of the patients, because you know, are you concerned that, because obviously it's quite a dramatic thing, you're telling me they can't even make a claim.
Well, I don't think they can't do that. I can't illustrate the difficulties of their case, because I always, with the work cover claim, I always try and explain the statutory law aspect to it and stuff. And you can get a bit of an idea of what's going on. You kind of, this is where you have to feel like doctors, you have to decide that patients, some patients that are touchy-feely and some patients that are very stoic and so on. You just have to sort of.
It would be sometimes very good to hear from the lawyers beforehand, and just discuss it, and just see where it may go, but they can probably counsel their,
Yeah, I think a lot of lawyers are there,
they do that.
their clients to tell them that what to expect. Not all of them actually. A lot of the work cover claims managers don't really tell them why they're here. I think, and they really struggle with it. Yeah.
So they,
So that's
people in here are
beneficial.
quite shocked, and quite stressed, and.
Yeah.
But
Do you think it's beneficial if they're sort of aware of the process?
Well, I think, especially when I was setting them for impairment, for example, that they have no concept what impairment is.
Yes.
Of course, there's no compensation for pain and suffering or loss of immunity under statutory law. It's only common law that they can do that. So a lot of them don't have these concepts. I still can't do the job, but
Yeah, it's not covered.
you know, anyway. So these are the other things. I won't go into details. There's something called coherence. You know, is the association consistent with the known facts of whatever's happening? The experiments are more to do with medical conditions more than an injury situation and so on. The same with analogy. So with scientific-based causation analysis, you need really peer-reviewed literature. And to be honest, in medical legal settings, we don't get challenged on it by the lawyers or the judges or anything like that, because it's not unusual for me to, maybe something unusual. I'll write a report and then I'll do a quick literature search and I'll find a paper that supports my case maybe. And I've got a whole library of papers on, for example, cervical disc degeneration, lumbar disc degeneration, etiology, prevalence, and so on and so forth. So I can kind of pick papers that suit my case for it. But a lot of us maybe don't critically look at what the paper quality is, because some papers are like rubbish and some papers are very good. But I don't think the legal system as discerning as you maybe should be in that situation. So it is what it is to do that. So just so you're aware about it. So this is
What was that?
yeah.
I said it's not really the case.
Yeah.
You should probably explain it like that.
There you go. So this is what's called the so this is what's called the hierarchy of medical evidence. So the best evidence at the top is the systematic reviews, critically appraised topics, and so on and so forth. And you have your different studies, and then the bottom one, funny enough, is expert opinion. The judges will often rely on expert opinion. I know, go figure. Anyway, it's got to be nice to the judges. Okay, anyway, so it's just worth knowing. So, but that doesn't get critically appraised. In causation, of course, the clinician, maybe the doctor treating the patient will say, "Oh, mate, it's possible you could have needed it at work." But then a researcher will say, "Well, that's the statistical association," and then legally, it's like greater than 50% of the stuff. So that's all relevant. So what you're doing is trying to balance medical, legal requirements that indicate it does vary from state to state and territory to territory. So this is what I was alluding to before. The quality of information available to us varies a lot. So your low quality stuff is just search on the internet, find something, or maybe something on Instagram or whatever it happens to be. And then you get the top quality stuff is your evidence-based systemic reviews, and then in the middle, other stuff. So all of that's relevant. You've got to be discerning what you really do. So these are just common causation questions, really. I'm not going to necessarily give you an answer unless you want to ask me. But did a low impact motor vehicle accident cause permanent low back pain? Well, I saw a fender bender was in Townsville on Monday. Literally, their bumper was cracked at the back. And then this claimant happens to be Korean. There's a whole story about Korean fruit pickers, which I can tell you about, and the number of legal claims, because they ring their lawyer before they go to see their GP in Brisbane, because it's all advertised. We have that. So it's interesting, and there's certain law firms that look after them, and certain GPs that look after them. Not that I'm cynical, but anyway. Anyway, so, but they, actually, it's interesting, it's a cultural thing I was alluding to there, really. They tend to have quite a high pain reporting after minor incidents. Really, so, so I think some of them are putting it on as overstatement and embellishment, but I think there's definitely a cultural thing which I haven't quite delved into, which is interesting. So, but if you, in a low velocity motor vehicle accident, the lumbar spine does not get stressed significantly. It's well supported in a seatbelt. There's not a lot of stress going through the lumbar spine. So really, it's not biologically plausible. You can have constant low back pain for 12 months, which is unchanged. That does not make sense.
You got a study?
No.
So,
No, I was going to say yes.
No.
yeah,
So it's difficult to, you know, just looking at the forces and stuff like that. And there's a minimum velocity under which you can't get actually physically injured. There's some papers on that. And in Germany, for example, unless the impact is over a certain amount, there's no CTP.
Generally, we feel like we're pretty clear.
So that's quite interesting. So the second one here, did lifting a brick at work simultaneously causes cervical disc herniation and make pre-existing asymptomatic lumbar products to the vertebral disc permanently symptomatic. So can that one movement cause all that problem? The important message here really is that lifting a brick at work would not cause degeneration in a neck or lumbar spine. You have to have had pre-existing degeneration earlier, and that's the etiology of lumbar spine.
Step one, yeah, actions.
So, you know, to me, that's a relatively innocuous sort of injury. I mean, clearly, if someone was lifting inadvertently 50 kilograms bent over incorrectly, I can certainly see why you could have an aggravation and/or acceleration of a lumbar spine condition, which may be an asymptomatic prior to that, but it does not cause degenerative change. Right? That's, you have to have a, you know, if I dropped James 3 meters onto his backside from the ceiling, he wouldn't rupture a disc. You'd get a compression fracture. Okay? Unless you've got this pathology or anything like that, then you might be some.
Thanks.
You get the idea that, you know, a young person, for example, you fracture it so, the disc is so strong, you're able to fracture your spine first. Another one, did low impact motor vehicle accident cause fibromyalgia? The short answer is no. Anyway, but you see it, here's another one. Did limping from a meniscal tear in your knee cause a lumbar disc herniation? Well, there might be a cause in fact, but it's not a possible cause legally. That's not biologically possible. Did a light factory job performed standing cause degenerative disc disease, you know, so-called cumulative trauma and so on. Another important one, does a lack of use of an injured limb cause injury to the contralateral limb, the so-called overcompensation injury? There's no scientific basis at all for that happening, unless you have, for example, a bony or above knee amputation and you're doing terribly, you can see how you can get that type of thing. So I do let it slide a bit with someone who has really bad limb. You know, you could aggravate a long spine condition, for example, that type of thing.
But over a short period of time, you've got to leave on one leg for say 3 months. It's like not really enough to actually cause.
You might have an exacerbation, aggravation. You know, it depends on the amount of degeneration of the spine and large.
Surgery on half the and over time how do you have a
Yeah, there's not overcompensation. If they take the evidence shows they actually use their legs less and they're much less active. They can't be, it's a kind of assumption that because they're not using this limb, this one does double the work.
Very less work.
Yeah, but actually, there's no evidence to support that. It was often used in that system, and then you can see intuitively, if you're not medically, if you don't apply all this analysis, you can see why, you know, the lay person would assume, oh, usually I've got this, must be related. The emphasis is it plausible and so on and so forth.
it is quite common that people start to store properly.
Sometimes I think it can be related, but generally speaking, there's no evidence to support that.
It did shoot as well. I think there's a certain exercise.
So if you're going to pick that up and something, he's had root times a day, all of a sudden, you know, 20, you get fatigue, muscle sore.
So achieve.
Yeah. You find, actually, most of these are the conversation injuries, not people who have gone back to work. And I can see why if someone's gone back to work and then, you know, they normally use students, but they're doing more than the other. I can see that. But most of the patients who deal with this will claim to say off work, at home, doing not very much.
Yeah.
Really? I think so.
I think we would have to.
So you've got to get to say.
Back to, you know,
Thank you, full time. So,
No, because you've also linked.
Yeah.
It's the first one is related to work.
hold on, then, I mean, it's,
Yeah,
so I can understand why things might hurt when we shouldn't, so then they become genuine. Various sides. So I think if I had to give an expert opinion as to why someone might be concerned in an unrelated side, let's say, probably lack of use. Rather too much use, if that makes sense, I think there are people with vision.
okay, it's not, executive swelling and.
You can get something on using reports as a consequential injury. So I think one thing can lead to another. I think it's so individual though on the circumstance. And it's actually, to be honest, really depends kind of like your report. I'll do a conclusion or summary. It's how you argue, sort of like being legally, it's how you argue your case, I suppose. So you know, a lot of the I think argue my cases pretty well and how I do. My painting colleagues don't always do that, so I'll have that. I must relate it. That's it. You know, there's not much science actually, to be honest. Anyway, so I like this term, metastatic pain. Where someone's got pain from him, it's supposed to be full of it is what it is. You know, then there's all these, you know, there's, you know, minor trauma like bending, lifting at work cause a strain injury that should be, and that cause chronic low back pain. There's not really much, you know, ligaments and all that sort of stuff.
There is no such thing, is that what you're saying?
You can, I don't understand. They normally recover though. You expect them to recover
Yeah, it's not really.
within 6 to 10 weeks. So something's going on beyond then.
Yeah.
Of course, once you get in a medical legal sentence, pain going 12 weeks, there are inevitable psychosocial factors going with it, you know, yellow flags. You know, they've lost their job, or, you know, work up and not playing ball, etc. You know, so we get all these difficulties coming in.
Yeah, it's subtle, it becomes subtle.
Yeah.
sometimes it's gonna be full money, you know, for a pain, that like you got pain, but then because of that knowledge, not to manage to do the skills and maybe then after time.
Yeah.
it costs for it.
It's critical to get it managed properly right at the beginning. If it goes out,
Only the no we.
Yeah. as soon as you get, you know, and actually, to be honest, physical conditions don't generally cause constant pain. They can, but generally speaking, not. So you've got bursitis in your shoulder. You don't normally have, you know, they're not at high pain levels. And they've got the central sensitization issues going on and so on, which makes it difficult to manage.
If it's a work-related injury, our theories revolve around the fact that pain therefore should be activity related. So when it becomes a constant, unremitting pain, that to us is a malignancy or an infection.
Yeah.
A constant
Yeah.
level of pain.
Constantly, like,
Well, even at any level,
you said that.
rare to have a
But it's rest.
Breast pain is, to me, the flag. So breast pain is,
Yeah.
I start thinking of the cancer.
Yeah, when they're first, I mean, you can have a constant pain, for example, and an arthritic knee, it's really inflamed. But normally the pain would, you know, if it's constant pain and a low ache, for example, you know, you expect with rest, it would reduce, it'd be a lot, but.
Okay,
The big difficulty with patients that have a prone to have constant pain without this central centralization, it's incurable. Can't cure it, all you can do is manage it.
That's very.
So that's a good thing. You know, and a minor rear end collision does cause lifelong pain. To be honest, I don't see many elderly patients whinging about their whiplash injuries from 40 years ago. So, funny enough, I suspect they all get
When
those.
it's no conversation, tell me about it. See, you've got some pretension there.
Well, in Lithuania at one point, there was no whiplash injuries because they didn't compensate.
It was a big spot, so obviously,
I don't know if this is how the businesses do it.
that's excellent. Yeah. That's the way the business system.
Anyway, so this is going back to causation, biomechanics, common sense, biological plausibility. Okay. Now this is just, I'm trying to put some science up. I haven't checked what level of science they are, but I think they're quite good. So the question is, does minor trauma cause serious low back pain? And you can look at it later on if you want. The bottom line is minor trauma was only associated with serious low back pain and compensation settings that are funny that, isn't it?
Except for one.
Yeah, but anyway, so this is the science behind what we're trying to talk earlier. This is another study. So it's looking at basically MRI monitoring. So basically they had baseline MRI findings, and then they looked at it 5 years later, and the findings on MRI imaging within 12 weeks of a serious low back pain condition are highly unlikely to represent new structural change. So often in a back pain setting, they get the MRI scan and they say, oh, those findings must be related to that event. But all the radiological series don't really support that. I mean, you can get an acute prolapse disc, for example, and then you would often would see probably big change in the MRI findings. But if you've got generalized degenerative change, you can't really attribute them to one. So, you know, sort of the typical prolapse disc, that's a little bit different. But you can always pick that up. This is another one on the etiology. This is and pathogenesis of disc degeneration. So you'll often see in the medical, well, legal brief, you know, Joe Blogs has been working 50 years as a truck driver, and therefore that must have caused these disc degeneration and so on. But actually, there's a substantial influence of hereditary genetics in this, not so much work related to this. There's not many work related things that people ask about. I mean, I think work can aggravate and accelerate at one level. But there's a lot of, I don't know if I mentioned it here, there's a lot of twin studies done where there are two twins, one does a completely sedentary job, one does a heavy manual job, same level of degeneration.
Oh.
And there's actually a lot of studies on it.
So studies on generation plus
not really, because you can have, for example, the same degenerative change in apparently on X-ray, and one person is symptomatic and the other's not. And we kind of attribute the pain must be due to that, but actually you don't really know which bit of it's causing the pain.
So I mentioned most people through generation. It's not.
Anyone who's over 40, well, actually, I've seen a prolapse disc in a 14-year-old all the time. So
It's just not an accusation. But with all those generations through most of it's then each time science is following through, it's an aggravation through system generation. And it sort of almost lessens the injury, whereas opposed to it's for an injury.
Yeah.
That's the issue.
Yeah, I think in a degenerative situation, you know, working is not going to cause degeneration, so
The aggravation.
yeah, of course, an aggravation, acceleration, and what you want to call it. I mean, to be honest, a lot of how we write our reports just keeps us all in business in a sense, as long as you're not straying too much outside the norms. But I think a lot of patients misdiagnose. To be honest, you know, as I see not uncommonly, someone has an injury, they attribute it to non-disc spondylosis, but there are a lot of conditions out, including on nerve entrapment, for example. I've seen a few cases down the track, which has nothing to do with degeneration. They've actually got a trapped nerve in their backside. So, and a lot of people see them post off, and they just get misdiagnosed.
There's not you guys are saying players.
Yeah.
And it's kind of speculating on this. There's no studies to say.
Right. Well, we get asked, I get asked all the time, you know, if it but for this, and I always say, well, I estimate 2 to 5 years, but I always know this is an educated guess, which it is.
Yeah.
One of the concepts is trying to get across from a medical perspective to a legal perspective is that you know, the degeneration is ticking along, we're all degenerating, very comfortable with that, you accept that we're degenerating. But to get a prolapse disc requires a huge amount of force. So you might say the guy from the very so you can put a 25-year-old through a roof and land on his bottom. He will not pop a disc, he will break his bone instead because his bones are soft and more vulnerable than his disc. Right? And we see a disc thing that just keeps degenerating until these two little problems. But in fact, to actually rupture a disc, it's a rupture, it's not just a slide or a a little bit of a bit of tissue that just disintegrates because you look at it. It takes quite a bit of force. And a lot of these degenerative, long-standing degenerative discs are actually quite calcified and robust and hard. And you go to operate on them and do a discectomy, you also to chip into them. That whole sorry, chisel. Chisel. To like to look at a older disc, it's quite hard. So I think what he's saying is this whole sort of school of thought around progressive degeneration and accelerated degeneration. What the way we see the world is these high energy injuries. There's the tissue damage.
If you take the original skull principle, you've got a middle-aged worker doing all the days potentially unsafe to need to do something that isn't a high velocity injury, they do products these. And you're saying that's so they're doing unsafe thing.
Yeah, well, and that's, I think that situation is clearly a work related to it, and this is aggravation and acceleration thing. But the actual patient might be that if you wasn't at work and just happened to be at home, it meant you might have opted to stand. It's just, it's, in that situation, it's fortunate to do it at work, maybe. Not if he loses his job. So I think it has to you can rupture a disc in trauma like a fracture dislocation in your neck. You can actually shear a disc, but that's pretty high velocity to do with. And normally, to work situation, the important thing to know is the disc is already degenerated. If you get a disc problem, something's already there pre-existing. It might have been just ready to pop, or there might be quite considerable force to actually make it accelerate quite a bit, or not so much. It can be quite picking up something off the floor, for example. So it just depends on the injurious mechanism. Anyway, this is hereditary is very important on that one. So this is the recommended steps and scientific causality determination: identify the injury, disease, verify the diagnosis, obtain evidence, review and assess the causal relationship, consider all the relevant factors, judge the validity, and then draw evidence-based conclusions. We're just trying to do your job properly with it. And this is what maybe lawyers expect, depending on which side of the fence you are, I suppose. So you want familiarity and skill in analysing, researching causation, and have a basic understanding of the jurisdiction, which I alluded to. Victoria is different to Queensland material versus significant. And this sickness and accident policy definitions driving now, because they word it a really wordy way to understand that. Treating doctors, greater than 95% probability of accurate diagnosis. Something on the side here that 20% of patients are misdiagnosed often at the first consultation. That's what the statistics show. So if you misdiagnose someone, you tend to treat them down that pathway, if you like, and you get what's called attribution error. So you make everything fit, the x-rays and the physio, or whatever it is, and actually the diagnosis is clear. And I've seen that a few times. So I feel that's one of my roles in work cover situations where I've seen claims being misdiagnosed and so on. So, it's not that I'm the best doctor in the world, but I'm looking at refreshing a pair of eyes when everyone else is kind of off blinkered.
There's and it's time, ways, and material price, and just
All of that, yeah.
Doctors, in that instance, who's accountable for that?
For
The misdiagnosis and part. Is anyone else?
Gene effect, this one narrows the focus this way, this one narrows the focus that way, and then you get that group.
Also, it's not not accountable, it's just, it's a vagary of lesson really.
Yeah, so that was come up with the lawyers,
So they've had 3 operations and 3 different surgeons. Together, they'll actually, the law firms or the workout will actually join and get me to the course rate practitioners at their percentage of that.
yeah,
So we go, because, and they'll get, which they need very much things for their state and sense, there's enough to do in the property, so they'll be kind drawing. All the forwards, kind of, as
That's the rubber that did for the knowledge, but generally say, just send it around to someone else and then just, like I say, they just look at it with fresh eyes and start again. And then, no,
give you honest feedback.
how do I not see it?
But some things only come with experience, as you get more experience as a doctor, it's all about, maybe it's more as well, it's about pattern recognition, so, you know, the experience on you can virtually within a minute know what the problem is, just by the patterns, whereas when you're younger, just learning, you have to be more deliberate about how you systematically go through it, and we still do that. Something unusual, although once back to the beginning, so tell me about that, how did that happen, you know, what's this, really trying to piece it all together. So that's kind of one of the satisfying things about this sort of work. What else have we got here? So this is all the crucial information you need to come to a valid assessment, you know, pre-accident medical records, post-accident records, objective physical signs, objective non-organic physical signs, you know, research articles, and then you obviously talk to the claimant as well. So there's objective and subjective stuff you have to use in the whole mix if you have the right diagnosis. And then you've got causation for old versus new injuries. This is all pre and post-accident information, evidence really. So it's just analysing the information you have. The main problems probably for lawyers with IMEs and the doctor is not doing their job properly in terms of causation analysis, not really asking the right questions from the claimant, not using evidence-based knowledge, equivocating opinions, kind of sitting on the fence really. I mean, you have to get like opinions, so, you know, maybe this and that doesn't really help, you know, uncertain opinions. And sometimes I've been guilty of that as well, doing what's called an internal inconsistency. I said X is not really responsible for Y, but then in the impairment, I find the proportion of it doesn't make sense. It's either, you know, and it's fine to actually correct your opinion as long as you validate. It's best to do that rather than stick to an opinion which is not actually very good or based in science. I'm quite happy to change that. I've even done it in court evidence before. You don't want to do that. You know, it's always like you completely do all anything, but you know, you can make concede points, you know, and overall there's in courts to help the judge make a decision. Mostly I do tribunal stuff, actually, so help. Anyway, so I hope that's there's a bit more to doing an IME than it would appear. And I hope that's been of some benefit. Thank you for having me. If there's questions here, what do you get?
Yeah,
Here as well.
but sometimes we get questions online if they raise their hand. At the beginning, you were talking a little bit about fraud, and I just wonder what your thoughts are about the medico-legal patient relationship and the therapeutic patient relationship. I think, and I'd like to hear what you think, with a therapeutic relationship, I'd just throw it all out there and trust the patients telling me absolutely everything completely honestly. And in a medico-legal relationship, it's obviously quite different. I just want to hear how you manage that sort of that trust relationship. Because I've watched you and I think you do it very well.
Yeah, I think what I always try, I don't assume that they're putting it on as soon as they can.
Yeah.
Something that some of the plaintiff lawyers don't like me doing, I get them to fill in a form before they come, which is very illustrative sometimes. The basic facts are, you know, where you live and whatever, it's fine. But there's a diagram on the back to show them where their pain is, so you can get a very good idea what sort of claim it is. They fill in the whole man figure, and they've gone outside the man figure and filled it in, then you know you're in for a hard time. Well, you know, not a hard time, but you know, you think, okay, this is going to be challenging. And also, I get them to fill in a pain disability questionnaire, which is highly helpful. there's something called the PHQ 15. If they get very high scores in that, you know, a lot of their pain has nothing to do with physicality, it's to do with the somatic manifestation of psychological distress. So inevitably there's depression, anxiety, adjustment disorders, and all that sort of stuff, which all go from next. So it's sometimes useful. And I generally pre-read and have time for all my file review before I see them, so I've got a very good idea. So I can do something quite efficiently. And also, you have things you don't want to get into a fight with anyone. So you just what you got to do is be nice to them. I'm trying to extract the information, and then probably be a little bit careful how you write stuff in the report. You're going to say, "Oh, this guy's clear now about fraud or something like that." That's probably not a slowly bit. But you can write, you can drop little things into the report. The defendant, lawyers, and insurers find it helpful.
When you come to do your permanent impairment assessment and you sort of, you look back at the diagnosis of muscular strain, or you look back at the causation, leaning over and you think, oh, is it really related? Do you just disregard that and do the permanent impairment, or do you tend to comment?
For work cover,
Yeah,
they have an accepted injury.
yeah,
And
That's
I may disagree with the accepted injury, but
Yep.
that's irrelevant. I still have to assess the impairment anyway. That's what we do in the tribunals, on the tribunals as well. So we may, okay, well, they accepted it, see accept. But it might be if they've had a wrist strain injury, and that really should recover, but they still have a lot of pain, and you may actually attribute 0% impairment to the work-related injury. As long as you justify, you've got to explain why you've done it.
oh, okay, yeah, that makes
As long as you explain why you've done the work, come to your
sense.
conclusion, that's what, if you just say that zero. What's going on? You got to explain why, the inconsistency.
Yep, yep.
As long as you explain yourself, then by and large, it's not. And actually, I used to think that getting lots of requests for supplementaries and clarification would be pain, but it's actually fine to do that because it's just all you're trying to do is clarify if you like get the right result for the claimant, whatever it's doing. It may be in their favour and may not.
When someone's had an injury that, like you mentioned, should have resolved after a period of time and hasn't, which may be due to, like you mentioned before, the wrong treatment or psychosocial factors. Can you attribute an impairment due to factors like central sensitization and whatnot that's then, I suppose, compensable for that person because of it's part of the.
Yeah, it's probably hard to with the physical injuries unless they've got specific pain disorders such as complex regional pain.
Yeah.
And they have to have specific criteria for that. And there's a pain chapter in, like Epi, for example, on the work cover. Comcare, there's one as well. It's a little bit tricky, I think, under CTP, but often they have a concomitant psychiatric disorder almost certainly. So they probably get, if you like, more impairment or compensation for the psychological aspect rather than. Yeah. Occasionally, if the whole thing is inconsistent, with the AMA guide that we use, section 2.5C, I cannot assess the claimant because it's inconsistent. So, and I've written that not infrequently, and I've how many times we challenged on it? Really? No. No. So I say, I'll just, it's really, they come with a back injury and then they've got abnormal noise for head. I just say, I cannot assess them because you can't measure the impairment. It's inconsistent.
That's like when they pick something up off the floor in the way you read within the carpet for the 10 degrees in the office.
Yeah, well, that's more going to the veracity of the claimant's case, I suppose. So it's quite complex.
Yeah, so like inconsistent with the structural initial injury.
Yeah, we've got specific tables that define your injury from your injuries.
And it doesn't give you any criteria to go to relate consistency with psychosocial things like fear avoidance and things like that.
Yeah, well, that's not really comfortable. It will come into the assessment, maybe in terms of what they can and can't do, for example.
Yeah.
So the impairments is one aspect of the sort of the compensation for pain and suffering, loss of immunity, and then of course, the ISV values, interest severity values, the judges. We don't stop. All you do is help them out. System.
So we thought you were just saying about, so, following up with certain, so I think this was about the children name. And if we're saying it's the whole show, but you should go very bad, it's just having. Can't be the whole show. Very specific. But the joint thing is that passing great, children. So then it's going to be.
Yeah, it's just got to work out. I'll show you this other stuff going on. And it's not our role as orthopedic surgeons to comment on psychiatric conditions, but I can. Some of my colleagues don't want to do it for some reason, but one of the difficult diagnoses is psychological problems that we shy away from, but it's actually highly relevant to my, whether there are psychosocial factors influencing presentation.
If you're asked that from instead of pushing you,
I'm quite comfortable with it. I do none of it. It's all the flags model, red flags, yellow flags, black flags, all alludes to psychosocial stuff. I'm not just an orthopedic surgeon. No, not just I'm an independent medical examiner, and I'm trained to do it. Yeah. So there's an overlap. So it's not just exclusive. So I'm completely up to date, AMA 4, AMA 6, master certified independent examiner. I don't need much better. I do a lot of it. And actually, your medical legal practice really goes into the reputation. People know you by reputation. It's just got to be fair.
I might be there in space.
You've got to be fair. You don't want to be an outlier either in places of the world kind of. It's nice, happy. Lawyers are happy. Actually, interesting. Are we still on?
Yeah, it's still, we tend to, thank you very much for your presentation this evening, and we're always very grateful for the opportunity to continue the discussion.